I'm Dr. Yin from Taiwan. It is my great pleasure and honor to discuss with you procedure tips and tricks for percutaneous closure of mitral leaks. As we know, leaks is a relevant complication after both surgical metallic or bioprosthetic and the transcatheter bioprosthetic valve replacement. Leaks are the result of an incomplete seal between the sewing ring and annulus for surgical bioprosthesis, or stent frame and the outer annulus or calcified leaflets for transcatheter heart valves. Approximately 1 to 5% of patients undergoing mitral or aortic valve replacement experience some sort of leaks with a varying clinical importance, ranging from asymptomatic to life-threatening. Repeated surgery has usually been considered the first choice to solve this problem, but it carries a high operative risk with mortality rates of up to 16% and an increased risk for re-leaks compared to the initial surgery or procedure. Advances in 3-dimensional transesophageal echo and the 3D or 4D CT have greatly improved our evaluation and planning prior to percutaneous closure. So after diagnosis, we can evaluate the lesion and determine whether which kind of treatment should be. 3DT is useful in quantification of the shape, size, and the severity of the defect. As shown in this slide, we can clearly identify where the leak is, and we can evaluate the severity of the leak before and after treatment. 3DT can also guide the transcatheter procedure. You can see the wires through the leakage and the occluder after deployment. The clinical indication of leak closure are hemolysis and or PVL-related heart failure. We can evaluate the risk of surgery and the likelihood of success of intervention before intervention. Because the physical characteristics of the surrounding tissue are difficult to determine and their response to closure device nearly impossible to predict, varying types of PVL closure devices have been used. Some of them perform very well, for instance the VP3 and the PLD devices, but they are not widely available for use. In Taiwan, the most commonly used device is the VP2 and the ADO2. To our experience, the shape and track of each PVL also varies. The shape of the PVL are usually oval and crescent in appearance. In addition, their track are rarely parallel and often run perpendicular with a serpentinous course. In our center, we divide the PVL into 4 categories. Type 0 means isolated or separated oval-shaped PVL, which can be fixed with one occluder. Type 1 means long slit-like defect, which may need one or more small occluders. Balloon-assisted catheter crossing may be needed. Type 2 means a larger crack, irregular shaped defect, which may need one or more different sized occluders. Type 3 means big crack, large defect, which may need more than one occluders in a row. For type 1 and to type 3 defect, the concept of multiple smaller devices rather than one or two larger devices have been suggested to have better sealing within the PVL and less interference with other cardiac structures or outstretching the surrounding tissues. The location and the numbers of the defects may determine the approach. Much of the approach to percutaneous PVL closure depends on the locations and numbers of the defect and the vascular access difficulties of the patient. Percutaneous approaches to mitral valve PVL closure can be summarized in this figure. You can do the procedure antegrade via transeptal through femoral or jugular vein, or retrogradely through transapical or transfemoral or transbrachial. Or you can do bilateral approach from transfemoral plus transeptal. For mitral PVLs, there is a rule of thumb. Usually, we divide the location into 3 areas. If the area is anterior located between 1 and 11 o'clock direction, transfemoral retrograde approach may be better. For lateral located defects from 7 to 11 o'clock direction, transeptal, antegrade, or transfemoral retrograde approach will be work. However, for medially located septal defects from 1 to 7 o'clock direction, transapical retrograde approach will be better. For example, in this patient with septal and the posterior located leaks, angulation of the caster and the delivery sheaths to reach and cross the defects from transeptal approach can be significant. A better solution will be transapical. On the contrary, a 7 to 11 o'clock defect is suitable for transeptal or retrograde approach. I show you a case with type 0 isolated, separated defects on either side of the mitral leaflet. We approach one of them first and deploy the occluder successfully. Then we switch to the other defect and deploy another occluder successfully. Finally, the 2 occluder can seal the PVL very well. This is another patient with a slit-like type 1 PVL at 3 o'clock duration. We use 2 occluders to seal the PVL. However, as you can see, even with the predilatation, balloon anchoring, the caster is difficult to cross the PVL. Finally, we use balloon tracking technique to advance the delivery caster into the LV. Then 2 occluders were deployed simultaneously to seal the PVL. This is another case with retrograde approach. This is a relatively large crack at septal position. The size is 6/3. So we use a retrograde approach. Initially, the caster cannot cross the defect. So we use a body wire technique and the child-in-mother caster. Finally, the caster can cross the lesion and the occluder can be deployed. After deployment of the occluder, as you can see, the valve becomes stabilized. This is another patient with a large defect on septal location. So we use a transapical approach. 2 large BP2 plug would deploy simultaneously to seal the defect. However, doing transcaster closure of PVL is not without difficulty. Sometimes we will encounter some challenges. The challenges for PVL closure is residual leak and the hemolysis, which may persist even if the PVL is reduced. Some of them may need reoperation, reintervention, or significant residual shunt or hemolysis. Common reasons of PVL closure failure are poor imaging and unsuitable anatomy, such as a big or irregular shaped, crescent shaped or multiple leaks and severe leaks with severe calcification, and inadequate device configuration. Some patients may experience device interference with prosthetic the leaflets. This may cause some problem, and the procedure may be given up. And in some patients already deployed the occluder, occluder may have migration and erode the leaflets, which result in severe complications needing surgery. However, this is not a real difficult procedure. If you can get familiar with the device and the procedure, in doing maybe 5 or 10 cases, you can become proficient in treat this kind of patient. So, in summary, paravalvular leaks are unfortunately but luckily relatively uncommon complications of prosthetic valve replacement that, especially when moderate or severe, have important clinical consequences. Addressing PVL requires a multidisciplinary team to properly diagnose this process and choose the corrective option most likely to result in success. With various technical improvements, particularly the introduction of specifically designed devices as well as improved imaging tools such as 3D facilitate the procedure, transcatheter PVL closure is now a suitable alternative to reduce surgery in patients at high surgical risk with appropriate defect geometries. I thank you for your attention.